January 2025. We're going to talk about protocol updates. So as a reminder, our purpose is to provide consistent, high-quality care to our patients when and where they need it most. And so I want to start off the day by offering congratulations. So our system was recognized by the National Association of EMS Physicians as the winner of the 2025 Quality and Safety Award for the work that we did in 2024 about increasing transport without the use of lights and sirens. That's a national safety measure, NEMSQUA Safety 01, and this is the work that we did over the course of the last 18 months. Starting in July of 2023, we were transporting sirens transporting without lights and sirens about 10% of the time. Through the course of these 18 months, we've brought that now up to consistently transporting without lights and sirens 88% of the time. I think we can continue to improve, but that's a function of how the whole system has worked together to do something that's proven to be safer for patients, to transport without lights and sirens. And there are potential exceptions, but the vast majority of patients can be transported without lights and sirens. Why? Because there's very little that the hospital still has to offer that we can't offer in the ambulance. There are specific cases, but we are bringing the care to the patients, and because of that, we're transporting patients in a safer manner, makes our community safer, makes all of the people who work in the field safer. I want to talk a little bit about philosophy as we talk about protocols. The purpose of our office is to support people that do the work. If I sit in my office and I write protocols, nothing happens. We do. So our focus is on giving you the tools that you need to take care of it. So outline for today, we're going to talk about the protocol process and a little bit about the philosophy of protocols. And then we have focused updates in each of these areas. Bulk of the day is going to be spent on Airway and one questions, one interaction. Today is going to focus on the why and a little bit into the how. Skill sessions in February are going to get deep into the how. And we're going to want your input. You can do this best. I'll get into that more later, but I guarantee that the people who are doing this every day are going to have better ideas than the people who don't. So we're going to talk about some updates with respect to trauma, updates with respect to pregnancy and childbirth. Just a reminder about our approach to cardiac arrest. There's some medication changes and there's some to county operating procedures. With that, invite questions in the room. Feel free to raise your hand online. Feel free to either raise your hand or put questions into the chat, and Mark will let me know as we go. So with respect to protocols, what are we trying to do in our office? We want the protocols to be updated to reflect current medical care. Knowledge about medicine changes, practice of pre-hospital medicine changes. So we need to update to keep pace with what's known about best practices. That said, they have to be clear. And so there's tons of science, but we have to boil it down into things that are clear, straightforward, and that don't put extra cognitive burden on you when you're dealing with tons of other stuff. And then finally, they have to be practical. Like, there are tons of great ideas out there that are just not practical in the field. And so our goal in writing the protocols is to make them as practical as possible. Why are we writing the protocols? We want to give you the tools to do the work. And so we want to put as many tools as we can in your hands to take care of the patients. So as I mentioned, we changed our protocol cadence, and we've also changed our protocol process. So first, with respect to cadence, Remember, these protocols will go live on Monday, March 4th, 2025. We're a system, function as a system. We're going to make the change together. In terms of the process, so in the last half of the year, we revised our process for how we update protocols. We'll get to these updated, clear, practical protocols that are useful in the field. So we moved to an in-person meeting with representation of agencies that provide pre-hospital care in the county. So we have back and forth document conversations between the Office of the Medical Program Director, between each of the agencies, thinking about what are the practical concerns for each of the agencies, how can this be implemented in the field, and it's a back and forth, because ultimately what we do is a collaboration. It's collaboration between EMS physicians, paramedics, and EMTs in the field, and I want this to be a back and forth about what works best. We did add pharmacist review of our protocols on 2 levels. So I contracted with David Castillo, who's a pharmacist in Southwest. He's been really helpful in giving us both a science-based point of view on what we're doing, but also a practical view about how are we going to do this, how are we going to deliver this in the field. And then as we talk about the dosing that also comes with a pharmacist review of the protocols. And so you'll see some tweaks. Primarily, those are a result of pharmacist review. And if you see it, like this is like the specifics of dosing medicines, if you just leave it to doctors, it's not always the best call. So this gets a little bit into the weed, but we're editing each protocol separately and giving it care, though trying to make each protocol and also make work together. And in terms of providing tools, we are adding checklists. None of the checklists are going to have something that doesn't appear in protocol, but the checklists are designed to be practical references that you can use in the moment, more practical than just putting the protocol up. And so while we are not going to make any new protocol changes until January 2026, we may update the checklists in response to your feedback to make them more practical. So one of the ones we've been working on and have gotten feedback is the stroke checklist. In developing the checklist, we worked with Sean Maxwell, who is the battalion chief assistant chief at South Snohomish. He has done extensive work on the human factors that go into making EMS safer. He's worked with NASA. He's done academic work about what makes a practical checklist. And so these checklists are a result of that. That said, when your feedback, the checklist only works if it's a practical tool for you to use. Any questions about philosophy or process before we get into the meat of the protocols? Okay. So as I mentioned in November, our focus for quality improvement over 2025 is around airway management. So we're part of the National EMS Quality Alliance Airway Collaborative, 50 systems from around the country who are sharing best practices about how to do the best possible pre-hospital airway management. So this is our bullseye for 2025. This is, obviously can't let everything else drop, but this is where we're going to put the focus on improving the quality of care that we provide. And the key measure around airway management is first pass test without hypotension or hypoxia. Why do we care about that? Okay. What our patients care about is that they're getting oxygen provided to the heart and to the brain, and not tolerate interruptions in the delivery of oxygen to the heart and the brain. Why does this measure what it is? And why was it identified by the National EMS Quality Alliance as one of the key things to focus on? Number one, we've talked a lot in the past about why first pass success matters. So this is a paper about the number of complications that you get with each subsequent intubation attempt. So that top blue line is the number of patients that had any complication. Those numbers below just break down what the specific complications were. The key thing is the more attempts you make, the complication rate goes up. And so for that reason, our focus is on first pass success. We have an option in the protocol for changing something and making a second attempt. But if we can't get a tube through the cords in 2 attempts, then we need to be moving on to something else. What about hypoxia and hypotension? So the worst possible complication of pre-hospital of any intubation, especially drug-facilitated intubation, post-intubation cardiac arrest. And so we know this happens. I'm aware of at least 3 cases over the last 2 years within Clark County. And we know that this happens in the emergency departments as well. So this is something that's been studied. And so how do you predict who's at risk for a post-intubation cardiac arrest? 1,
That's the microphone.
This should seem like it.
This microphone is muted.
Don't unmute it. Don't unmute it. As soon as they can listen.
Are you seeing the slides now? Okay. So we talked about the SAD greater than 90 before. Okay.
Yep.
Now we're starting to bring the whole measure together. So first pass success, no hypotension. As we would expect, we're lower on that number. And so first pass success without any hypotension before or after, that number is lower. Like I said, this is the target. This is one of the biggest ways in which we can improve our performance on this measure and make intubation safer for our patients. And then what about first pass success without hypoxia? So that's at 57% over the last 18 months. And remember that's having documented SAT before and after that's greater than 90. And so we're going to be giving you tools that are going to make it easier to hit success on this. So how do we do on a composite measure? I would say this is hard. This is a hard thing to do. This is something that requires a complex system to be successful. So our average is 17% success on Airway L1 over the last 18 months. We are not alone. Okay, so I just got back from the National Association of EMS Physicians meeting in San Francisco. This is data that was presented by Fort Worth. Their system is similar in structure to ours, roughly twice the size and twice the number of calls. So when they started working on this, we're at 17%. They were at 18% when they started working on this. And so they made a series of changes. This has been replicated elsewhere, and this is where this is coming from. This is the cornerstone of our approach. The research and development should actually be called rip off and duplicate. So we're putting a Clark County spin on this. We're doing it, but we're doing something that has been proven to work elsewhere. And so they started working on this, and they did their first PDSA cycle. We'll talk about what that is, but that's plan, do, study, act, how you improve things. The second PDSA cycle implemented. And so they're over the time, their average is at 45%. And then in the last month, they were at 65%. And then they just reported November and December of 2024, they were at 70 and 72%. So what is our aim? What is the thing that we're focused on doing? Okay. Our goal is to improve performance on Airway 01, first pass success without hypoxia or hypotension, to 60% by December 2025. How are we going to get there? So number one, patient positioning. And this is something that we do now, but we're going to optimize because and there's no significant change in what we're doing, but it's still that you're having the patient elevated, you're having the patient in a sniffing position. We're going to do pre-oxygenation with positive pressure. This is a change. And this is primarily in response to a really important study that came out in the New England Journal of Medicine in June of 2024. And they took patients that were being intubated and randomized them to get pre-oxygenated with an oxygen mask or with positive pressure ventilation, either CPAP, BiPAP, or BVM with PEEP. And there was significantly less hypoxia in the group that got pre-oxygenated with positive pressure. So this is a change in our approach. We're going to talk about giving you the tools to make this happen. This is giving you the tools to make that happen. In most situations for us, I think the most practical thing is going to be a BVM with PEEP with the nasal cannula under it, so you're providing apneic oxygenation. Next thing, this is a change. We're delaying the administration of the paralytic. Another way to think about this is DSI for everyone. This is something that's been done Williamson County, Texas, Fort Worth, and several other systems. But it's essentially saying, so you can focus on the pre-oxygenation. We're just going to administer the ketamine as we start the pre-oxygenation. And we're going to give them positive pressure ventilation. And we're going to get the SAT above 94% for 3 minutes prior to doing that. We're going to continue with apneic oxygenation as we have been doing. And then we're going to hit goals for oxygen saturation and systolic blood pressure before we proceed with passing an endotracheal tube. Who is going to be critical for the success of this? Everyone, but especially the EMTs. And so for any of the EMTs that are listening, all of the things that add up to success here are going to be, with the exception of passing the tube, your EMT skills, positioning the patient, bagging the patient, getting a good fitting seal as you're bagging, making sure that you have an oxygen saturation on the opposite arm from the blood pressure monitor, and making sure that you're keeping the paramedic honest about what's going on here. So there is no way we will succeed without strong work from EMTs in making this happen. So we're building on stuff that you already know. So pretty much everyone in the county has been through the pre-hospital emergency airway course. And so this is the algorithm from the pre-hospital emergency airway course. Plan, prepare, and then perform. Goes into, so plan, look at the difficulty, look at hypoxia, look at the vital signs, prepare to take care of the ABCs, make a plan for Crike. We'll talk about it more, but one of the things in this preparation phase is we're adding the option of low dose epinephrine. And we'll go into that. So then you position the patient, elevated sniffing position, pre-oxygenation, and this is going to be with positive pressure ventilation, making sure that your IV and IO flushes and works, optimizing the oxygenation, figuring out, is this patient responding to what I'm doing? Do I need to adjust the position? What do I need to do? And then meds. And this is the change, and I'll show it in a diagram in the next section. This is where we give the ketamine once we've done those things. Then as we perform the procedure, we're going to continue with apneic oxygenation. We medicate once we've reached those physiologic goals. To simplify this, rocuronium is going to be the first line, because it works for almost everybody, and we have one small carve out where we'll use succinylcholine. Intubate, doing all the things you can to maximize success. Video laryngoscopy, bougie. Confirmed tube placement with waveform and tidal CO2. Get your post-intubation vital signs, take any action on them that you need to. Maintain your sedation, which will be particularly critical when we're using rocuronium most often as the paralytic. And then any NG or suction as needed, depending on your time. So I want to get into a little bit more details about the changes and how we're going to operationalize this. So in your planning phase, you're getting your systolic up to 90. Now, keep in mind that for trauma patients, we preferentially leave them hypotensive. There may be trauma patients that we don't intubate. But what kills patients in trauma? The trauma. So usually, the diamond of death, the coagulopathy, the acidosis, the hemorrhagic shock. And so unless you're dealing with isolated head trauma, and you're just trying to maintain the blood pressure and maintain the oxygen delivery to the brain, a period of apnea is not ideal for most trauma patients. So we're going to get the systolic up to 90. We're going to give ketamine. We're changing the dose of ketamine from 2 milligrams per kilogram to 1 milligram per kilogram. Why is that? So as we learn more about ketamine, know that in patients that have a significant sympathetic drive, you give a significant dose of ketamine that can drop blood pressure. Ketamine 1 milligram per kilogram will dissociate pretty much everyone. If for some reason it didn't work, we're going to leave an option in for 1 repeat dose. We want to make sure that the patient's dissociated. But our starting line is ketamine 1 milligram per kilogram. This part of simplifying it. So rather than saying half dose of Shakti, we're just saying we're starting with 1 milligram per kilogram. It means we're less likely to have hypotension with the intubation. And then this gets the patient dissociated, so you can focus on pre-oxygenating the patient with positive pressure ventilation. Meet those goals, then we're going to give rocuronium 1.5 milligrams per kilogram. Previous dose of rock, when we did use it, was 1.0 milligrams per kilogram. Why the change? So rocuronium has a quicker onset and a higher dose. The most commonly used in the ED is 1.2 milligrams per kilogram, but there is evidence for 1.5 milligrams per kilogram. That way, keeping it the same as succinylcholine. Again, goal is to maximize simplicity, repeatability. You can get a patient paralyzed with rocuronium 1.5 milligrams per kilogram. Far fewer contraindications for rocuronium than for succinylcholine. So we can't meet those goals. We haven't resuscitated the patient enough that they're ready to be intubated. You can try. Say, for example, oxygen saturation drops down to 90 in that 3-minute period. You can change something. You can pre-oxygenate them, and you get 3 minutes of oxygen saturation greater than 94%. Go ahead and proceed with the intubation. You can't meet the goals, then go to the IGEL. So why do we go to the IGEL? Because we know that these patients that are shocky, hypoxic, they don't tolerate a period of apnea well. IG can be placed quickly, can be placed by EMTs. We can continue oxygenating the patient. The IG does give significant protection against aspiration. And what the patient cares most about is having oxygen to the heart and the brain. The patient doesn't care about the shape of the plastic. If you can't intubate or can't oxygenate, can't ventilate with the IG, then that's when you move on to cryo. And if you need to place the IG and get it working, then you have the option of giving your rocuronium at that point. Many people call that rapid sequence airway. So you're giving the rock so you can place the IG, but you're not giving the rock with the goal of intubation. What questions do you guys have about that? Okay. And we're gonna train on this in February, and we want to work through all the practical implications, how we make the team, how we get the team together to do this. But this is something that's proven to work. I have confidence in our ability to deliver this, and I think we're going to see some significant success. So reviewing the tools: ketamine 1 milligram per kilogram, rock 1.5 milligram per kilogram. When do we use sucks? So most important, status epilepticus. You need to know in the field, is this patient still seizing? If that is the case, where if there are no contraindications to sucks, you would give sucks. Head injury, new stroke with neurodeficits that you need to intubate. Those are patients where decisions are going to be made in the hospital based on the neurologic exam. 1.5 milligrams per kilogram of rock will keep most people paralyzed for about an hour. So if you think decisions, either you need to make a decision based on the neuro exam, or the doctors in the hospital need to make a decision based on the neurologic exam in the next hour, those are the situations where you can consider sucks. If the contraindications, use rock. And then we added the option of low dose epinephrine. We'll talk a little bit more about that, or fluids. There is an element of clinical judgment in figuring out if this patient is hypotensive, what do they need to get the blood pressure up? Okay, we're going to talk briefly about low dose epinephrine. Oh, yeah. So epinephrine can be given in 3 ways outside of a drip. So you can give epinephrine 1 milligram per milliliter, that for anaphylaxis or severe asthma. We can give it 0.1 milligrams per milliliter for cardiac arrest. And then what we're adding is the option of epinephrine 10 micrograms per milliliter for hypotension. You may have heard this called push dose epinephrine. We thought about this, talked with pharmacy about this. The reason we are using the term low dose is that, one, it's really clear about what you're doing. There are, I was asked a question about this earlier last year. I said, like, we're not ready for this because there is documented evidence of medication errors causing harm with this. This is, one of the small amount of times where we're mixing a medication in the field. And so it's important we mix it right and that we're clear about the communication. The problem with using the term push dose is that people can also say, well, weren't you telling me to push epinephrine 0.1 milligram per ml for cardiac arrest? You push that as well. So the key thing that distinguishes this dosing of epinephrine is that it is low dose. Legacy uses this term within the hospital right now. PeaceHealth does not. We had to make a decision about what we're going to do within the system. For clarity, for simplicity, we're referring to this as low dose epinephrine. We'll go into detail next month in skills for how to mix. But one of the key things I want to point out is that because we work as a system, come together as a county, we're going to have one way to mix this through the county, and that's taking 9 milliliters of normal saline, 1 milliliter of epinephrine, 0.1 milligrams per ml, and then you have 10 milliliters of epinephrine, 10 micrograms per milliliter. Just in general, 1 to 1, 1 to 10, those terms are not recommended to be used anymore. So we're just going to talk about the dosage of the epinephrine. It's either 1 milligram per ml, 0.1 milligrams per ml, or 10 micrograms per ml. Now, this next bit is a good idea with any medication, and I think it's particularly critical with a medication like this that has the risk of errors. It's a medication administration cross-check, where you're going with your partner and saying, okay, medication administration cross-check. I am going to give 2 milliliters of epinephrine, 10 micrograms per milliliter for hypotension. Are the contraindications? Okay, no contraindications. Okay, what's your volume? 2 milliliters, confirming that. Okay, then give the medication. We'll make this available. This is from Chicago EMS. This is, I think, a good idea in any case, but particularly a good idea in a situation like this. At the national meeting last week, talking about sometimes where you're on your own in the back. Obviously, this doesn't apply to the crashing patient. You can even do this with the patient. Just explain to them what you're doing. But this is a simple, no-cost measure that we can do to increase the safety. So going back to our aim is to improve performance on Airway 01, which is first pass success without hypotension or hypoxia, to 60% by December 2025. Like I said, I am confident in our ability to do this. The protocol gives you the tools to do this, but the protocol, you can't just write a protocol and then things change. So how are we going to get there? This is the model for improvement. This is how we make things better in a system. So what are we trying to accomplish? First pass success without hypotension or hypoxia. How will we know that the change is an improvement? We're going to monitor this on a monthly basis. Our goal is to get you feedback as quickly as we can on how you did on these measures. And we want to hear your feedback on what tools you need to help perform those measures. Was it the blood pressure cuff didn't work? The pulse ox wasn't giving a reading. The video screen went out. Like, the people who are doing the work are going to know best how to make the work better. And so then we're going to ask, what are the changes that we can make that will result in an improvement? So if you have an idea about how we can do this better, we want to hear it. And we're just going to continue these cycles, just little tests of change. How do we make this better? Really, the first set of cycles is going to be the training that we do next month. But the plan plan. So say, for example, we say, okay, we're going to try this new checklist, and then we're going to do it. We're going to test it. We'll test it in training. We'll see how it works. You may say, this isn't really clear on the checklist. We're going to fix that. And then we're going to fix that. We're going to make it better. And then we're going to test it. And so it's just these small changes, bit by bit, they're going to get us there. There's no one grand thing that we can do that is going to flip the switch and make it all better tomorrow. But if we each contribute ideas, if we each troubleshoot, if we each work on making this better, I'm confident that we can make it better. We want your ideas for improvement. Feel free to scan this now for anyone here online. Or you can go to clarkmpd.org/ideas. And there's a place where you can submit your ideas for how we can improve on this measure. And, when you're in the field and you're thinking, what could we have done better? What are the tools that I needed to be able to reach this goal? That's where we want to hear that. Because like I said before, the one thing I can guarantee is that the people who are doing the work every day are going to have better ideas than the people who aren't. That's what I have about Airway. I know that's a lot. Any questions about that? And we're going to, next month's training, we're going to get deep into this. We're going to operationalize this. We're going to get ready to go live on March 4th. Okay, trauma. This will be shorter. So we are making TXA available to all transporting agencies. The rationale for this, we'll talk about, we're adding TXA for OB indications. Everyone takes care of OB patients. Do we want to get things as well aligned as possible? When we think about what are we looking to do in the future, not in 2025, what were we investigating for 2026, 2027? One of the things that we're looking at is whole blood. And And so to be able to do something like that, number one, we want to be as consistent as possible with our approach to trauma. And number two, even in how we approach Airway, we're going to develop our ability as a system to implement complex interventions. And whole blood, definitely in terms of the logistics, administration, is a complex administration. So just to be clear, it is not coming in 2025, but it is something that's under investigation. So we're setting the stage for that. And then previously, the HAT resuscitation for trauma rest was in the death in the field protocol. And I just, when I think about like, what protocol am I thinking about when I go on a CNSC trauma, I'm not thinking death in the field, I'm thinking trauma protocol. So we're just moving that directly into the trauma protocols. Okay. OB and childbirth. So this is in response to some new information and also giving you tools. So one of the things that we've recognized over the last 10 to 15 years, there's been a significant increase in maternal death from eclampsia and related conditions. One of the issues in Clark County is that it's really hard for people to access prenatal care. But this is a national issue, and we're also just learning more about what puts patients at high risk for that. I'll go over the protocol on the next slide. Again, we simplified the dosing of medication for seizure. Again, we are looking whenever possible to reduce the cognitive load. We want clinical judgment. We don't want extra cognitive load that doesn't add value to the patient. And then we're adding TXA for OB indications. So this is what the protocol looks like now. And the key thing, so pretty much anywhere else in medicine, hypertension by itself, we care about it when it causes a problem. If someone's altered and hypertensive, if they're short of breath because they're fluid overloaded and hypertensive, we care about it. But we know that in eclampsia, the hypertension by itself leads to this pathology. And so to meet the criteria for preeclampsia is having any blood pressure greater than or equal to 140 systolic, greater than or equal to 90 diastolic. And those aren't numbers that would typically freak us out. We see those all the time. But in patients, third trimester up to 6 weeks after delivery, these are patients where we should be thinking about preeclampsia. So you'll also see headache, confusion, you can see visual disturbances. You can't see belly pain, the liver gets affected. Patients can get dyspneic. But the important thing is to be aware of this. What is a hypertensive emergency in a patient at risk for preeclampsia? It's a systolic greater than or equal to 160, or a diastolic greater than or equal to 110. So we looked at and talked with pharmacists, I looked over the data and said, okay, should we add medications to treat hypertension in pregnancy? Yeah, it is not something that we see frequently enough to justify adding whole new medication and the load that come with that. But I want you to know that these are patients that the minute they hit the door, whether it's L&D or in the emergency department, they're going to get medicines to lower their blood pressure. These are patients that are high risk for proceeding from preeclampsia to eclampsia. So the key thing is to be aware. Red acuity, turning on the lights and sirens does nothing to help the blood pressure. So the ED needs to know that they're coming and needs to know that they're going to need treatment and that they meet these triggers. They don't need lights and sirens. And then with respect to the seizure treatment, just wanted to simplify the dosing as much as possible. So it's 5 milligrams IV or 10 milligrams IM every 5 minutes until the seizure stops. And then magnesium. Again, we'd previously given a dosing range. Like people, we're just saying 4 grams IV over 20 minutes. Just get the midazolam on, give the magnesium. And then any questions about those two things? Okay. And then for postpartum hemorrhage. So just take a look. If there's an obvious laceration, you can apply direct pressure to the laceration. Otherwise, just applying pressure to the uterus. And And then if you have a patient that is shocky, either significant blood loss, systolic less than 90, heart rate greater than 120, get the exit. We know that this is something they'll be getting in the hospital. We looked at, does it make sense for us to carry oxytocin? Again, just not enough cases for us to justify putting oxytocin on every piece of apparatus. Remember that the nurse midwives in the community do carry oxytocin, and that's something else that'll help to contract the uterus. Any questions about OB?
There's like childbirth involved. Not to forget, like maybe have baby breastfeed a little bit.
Yeah, no, good point, good point. And so the comment was, if mother delivered a child and the baby can breastfeed, that can also help to contract the uterus. Okay. With respect to cardiac arrest, this is not a change in protocol, but we're just adding a piece of emphasis. We see this everywhere. With mechanical CPR, there is a tendency to try to get it on as soon as possible. And it does ease the workload. Remember, mechanical CPR has never been proven to be better than manual CPR. At best, it's equal, and we know that there can be interruptions with it. So at minimum, our recommendation is at least 2 minutes of CPR before considering application of the Lucas device. Now, I recognize there are times when there may be just two of you, but in general, just starting with the manual compressions is the most important thing that you can do for the patient. Questions about that? Okay. And then pulling medication changes together. So giving you the tools. For cardioversion, we are making first line for adults that need cardioversion. Sedation is etomidate, 0.15 milligrams per kilogram. Why are we doing that? It's more hemodynamically stable than midazolam. It has essentially no effect on blood pressure. And by definition, the patients that we're cardioverting in the field are unstable. It reliably gets people associated. Respiratory depression is very, very rare. The biggest thing that you'll see when you give etomidate without a paralytic, like we would for intubation, is that some people can have muscle tremors. Worst case situation, it can make the post cardioversion EKG a little bit harder to interpret. But typically you can troubleshoot the EKG, you can make that work. It's about 1 in 10 cases where you have enough shaking that it's a little bit harder to read the EKG. It's hemodynamically stable. It does not provide retrograde amnesia. So if you have a stable patient, for some reason you didn't sedate them, midazolam is still an alternative. But preference is, whenever possible, give etomidate prior to cardioversion. It is not a medicine that can be given IM, so IV or IO. Midazolam is the option that you have if you need an IM medication. Mentioned this before, but we just simplified midazolam dosing for procedure. IV, IO, 5 milligrams every 5 minutes until the seizure stops. If you don't have an IV, 10 milligrams, IM, repeat every 5 minutes until the seizure stops. Okay. And then with respect to medications, you have the option of a dosing app. The way, those agencies that use HandTevi can continue to use HandTevi, and your workflow will not change at all. For those agencies that don't, when we push these live, where it's in the quality checking phase right now, there is going to be a little calculator on the top right of this screen, and you tap that, and then that will let you enter the patient's size. You can enter a weight, an age, a height, a color tape. For the adult, you can enter their weight, and then that is going to take you. So you start in the protocol, you give the patient's weight, you give the patient size in whatever way is easiest for you, and then it's going to give you the dosing that's in the protocol in milliliters. This is dependent on, we have defined standard concentrations for medications within Clark County. The number of times that we have a different concentration is relatively low. We're going to mark those medications. If you have a non-standard concentration, then you need to know that you have a non-standard concentration, and then that dosing will not apply. For any other comments about that?
It also has infusion and an assumed drip set. So the assumed the 60 drops set with an assumed concentration which is on there. So not only a bolus dose, but the infusion and the drip rate are also in the infusion for both adults and infants.
Right. And I'm going to repeat that for the people online. So it also has infusion rates based on a 60 drop set. So you can give the bolus and then I'll give you the infusion rate.
And to everybody who has access to the app can use this, whether you have handset or not. Everyone using the protocol app can use it.
Yes,
And
it's
it
available.
was the concentration on there.
Correct. It lists the concentration of the medication, and that'll be the standardized concentration that we use in Clark County for that medication. And then finally, we heard from you that you wanted contraindications to the medication, clear list of indications and contraindications. And so we're bringing that back so you have a reference table of the medicine with indications and contraindications. Okay, and then finally, some updates to county operating procedures. Okay. So there had been a requirement to contact medical control for an alternate destination. We're removing that requirement. Pregnancy is no longer an exclusion for alternate destinations. Now, obviously, if someone's crowning, an alternate destination is not ideal, but if they're not having any issues related to the pregnancy by itself is not an exclusion. We also removed the pregnancy exclusion for buprenorphine. American Council of Obstetricians and Gynecologists recommends buprenorphine for patients who are pregnant with opioid use disorder. And then just a clarification that patients that are hypoglycemic, they used a short-acting insulin. So that's typically Lispro. And say they didn't eat or they took a little bit extra insulin, they have a clear cause. Those patients can be released by protocol. If a patient took an oral agent, you don't know why they're hypoglycemic. If they're refusing, that's an AMA refusal because those patients are patients that typically get admitted for monitoring of their blood sugar because those are long-acting medications. Similarly, a long-acting insulin, you don't have a way that people can keep an eye on them. That those are patients that are at risk for getting hypoglycemic again. And then this is in response to two things. So we talked about our work increasing the percentage of patients that are transported without lights and sirens. We have taken it out, last year we took out anywhere in the protocol that required transport with lights and sirens. One of the things that I've heard is we just give us some guidance about when lights and sirens might be indicated, when lights and sirens might not be indicated. The other thing that we have happening in the system is that some agencies that do not have ambulance licenses have aid vehicles, and we need to put parameters about when it is reasonable to use those when a licensed ambulance is not available. So again, how you drive is an operational consideration, and our preference from the Office of Medical Program Director is to stay out of operational decisions. But we want to give you some medical guidance about what are things where, when we consider that on average, you save about 1.5 minutes by turning on the lights and sirens. What are some things where there may be a benefit in the right operational conditions? There's traffic, there's reasons that you think the risk of using lights and sirens might justify that. So patients may read trauma criteria. They're going to be seen by a trauma surgeon immediately on arrival. They may receive whole blood. They may receive life-threatening interventions. STEMI, those are patients that have an identified STEMI, they're going to the cath lab. There's a time-sensitive intervention that cannot be provided pre-hospital. Suspected stroke with new neurologic deficits present. Those are patients that might get thrombolytics. They might get a neurointervention for their deficit. If you can't oxygenate and can't ventilate. If you have severe respiratory distress, and it's not responding to the treatment that you're providing. If you have shock and it's not responding to the treatment you're providing, And then just because it's not, just in case there's any confusion about whether this is included in red trauma, if you have a medical cause for uncontrolled hemorrhage, massive GI bleed, dialysis, fistula bleeding that you can't control with the measures that are available to you. Those are patients that are going to get immediate intervention in the hospital. These are patients that are not going to get immediate intervention in the hospital. If you just meet the criteria for yellow trauma, you're going to be met by a trauma team. But by definition, these are patients that might need the services of a trauma team. They haven't proven with the red trauma criteria that they need the services of a trauma team right now. If you have chest pain, but there's no stemming, there's no hemodynamic instability. There's good literature that says turning on lights and sirens increases catecholamine release, increases oxygen demand. So if you have chest pain, you have a 12 lead, and the patient's hemodynamically stable, that does not by itself require lights and sirens. Again, this is an operational consideration. And if you're a small distance from the hospital, the patient's having this crushing severe chest pain, looks terrible, and traffic is stacked up between you. I want to give you some latitude to make operational decisions, but I want to give you some rough guidelines. So if there's a TIA, but the symptoms are resolved, by definition, patients not having symptoms right now are not going to get an immediate intervention. The hospitals want to keep a close eye on these patients because they can develop. But if they're not showing a sign that they're going to get an immediate intervention, then there's risk to turning on lights and sirens and no benefit to the patient. If you have a patient that's intubated, you have stable vital signs. So say you intubate a young overdose patient because they weren't protecting their airway. What am I going to do when I receive that patient in the emergency department? What's that?
Oxygen.
Definitely, yeah. I'm going to order a bunch of tests that don't change anything, and I'm going to admit them to the ICU. So those are, you're providing the care the patient needs. You have stable vital signs, you've intubated the patient, you manage their airway, you're providing them what they need. If you have ROSC, but the patient's hemodynamically stable, doesn't have signs of STEMI on EKG, that's also not a patient that we're going to do something for urgently in the emergency department. That said, if they're hemodynamically unstable, you think they might need other interventions that you can't provide in the field, then you can consider it. In general, if you're triaging the patient yellow, that means should be seen by a doctor within 10 minutes of arrival, unless there's some significant operational concern, massive traffic jam, something like that. Those are patients that by definition are not going to get an immediate intervention when you arrive to the hospital. And then just meeting the criteria for sepsis, again, does not require lights and sirens. They can, unless you have shock that's not responding to treatment. You put them on a pressor, they're getting better, then you're providing them what they need, you're providing them what they're going to get in the hospital. But those are things that just by themselves don't require lights and sirens. Questions about that? I'm at the hour, so I'm going to wrap up and review. So one, we've revised our protocol process. We're going to continue to revise it. We want your feedback on how these protocols are looking, working. And so throughout 2025, we're going to be working on the protocols that will go live in January 2026. So with respect to Airway, we're working together as a system to make airway management safer. We want your input on how we can make this work. For trauma, bringing TXA to everyone, putting the trauma arrest guidelines in the trauma protocol. For OBGYN, recognize hypertensive emergencies in patients that are at risk for preeclampsia. And then we've added TXA for postpartum hemorrhage. For cardiac arrest, just re-emphasizing high quality manual CPR is the cornerstone of treatment. And especially, in terms of making your first shock successful, best thing you can do is get on the chest right away. We've added etomidate for cardioversion, simplified some other medication dosing. And then with respect to POPs, we've removed several restrictions, particularly around pregnancy, contacting medical control for alternate destinations. And we've added some guidance on lights and sirens use. So I definitely want your feedback and questions. Mark, if you're able to post post that into the chat. We always ask for your feedback on these lectures. In this form, we also are asking for your questions about the protocol. It may not occur today, it may occur later. Feel free to submit again. We want to hear what questions you have, what questions does spring up in your mind, what do we need to clarify? And then we'll have a skill session in February to really dive into the airway management and figure out how to operationalize it. Any other questions for me? Well, I really appreciate your time and attention. I'm really excited about what we can accomplish over the next year. I'd like to defend that award, but either way, I am confident that we can make this better and that we can really set an example for other EMS systems about what's possible. Thank you.